welcome all of you, my friends from different parts of this world. Now, first of all, I would say congratulations. You have all cleared your first hurdle, that is EDIC Part 1, and we are really proud of your achievement. And the story doesn't end there. So, after this EDIC 2 recently concluded, we thought of having one EDIC 2 recall webinar, which was like targeted to help the candidates know the detailed insight, how the exam was conducted, what were the questions, what were the important key domains, and what is the current updated exam trend. That is definitely going to help you all. So we conducted our webinar on 6th of December, and it was hugely appreciated. Almost 120 candidates from across the world, they have joined, and we had two of the faculties who have appeared the exam, last EDIC 2 exam, and they have shared their the ideas and the questions those were asked in the last EDIC 2 exam that was held in the month of November. Now we are now here to help you cross the last hurdle, because you have only crossed the first hurdle and the last hurdle is remaining, that is the EDIC 2 exam. The EDIC 2 exam is slated to be conducted in the month of May 2026. And yes, there are only 5 months, rather than I would say less than that. And for that, you have to start preparing from now, because it is not so easy. And we are from the 360 Critical Care is here to help you. And we, like the three faculties from the core 360 Critical Care, Dr. Sanant, who is from Australia, Dr. Jitendra, who is from Bangalore, India, and myself, Dr. Tapas, who are trying to formulate the course, the schedule of the agendas, and also we have two invited faculties from Saudi Arabia and Egypt who are here to help you out, like how the CCS, CBS questions and the different domains, what are the hot domains that were like asked and which is going to be again and again appear in your upcoming EDIC 2 exam, and how you should like use the different strategies smartly to answer to get the maximum marks in the EDIC 2 exam. Now, yes, we hope that by end of this webinar and also our upcoming TRICS 2 preparatory course, you will be ready to face any hurdle in the upcoming EDIC 2 exam. Now, one line I would say, or maybe one slide about what is 360 Critical Care, who are we? We are a dedicated critical care teaching and training academy for last 4 years, and EDIC 2 preparatory course, which is popularly our signature, I would say, course named as TRICS 2, Targeted Review in Intensive Care, TRIC 2, because we have one more also, that is part 1, which is TRICS 1. And definitely this course has helped, I would say, more than 500 candidates in last 3 years, 3.5 years, I would say. 7 EDIC 2 preparatory courses we have conducted, and we have a staggering record of almost 92.5% success rate. So we are the training academy preparing today's trainees for tomorrow's critical care. And it is not the only course that we have. We have also some of the flagship courses for the DRNB and DM courses, which is the final exit exam in India, and also some other courses which is also helpful not for India but also across the world. So our approach is, as we named it, 360-degree, integrating theory, bedside skills, decision making, communication, ethics, and evidence-based practice to ensure holistic readiness, not just exam success. And our mission to make the future critical care better, safer, and fully prepared. Now, with this background, we are here to help you out for today's webinar, which is the preparatory course free webinar for the upcoming EDIC 2 final exam. Now, the agenda that we have, the first one, that introduction part, what to expect in EDIC 2. Now, the second one by Dr. Sananta, who would be starting very soon after my talk CCS session. So he will be talking about the CCS question. Those were asked in the last, like the few EDIC 2 exam, and also his vision, how you should be preparing to get the maximum score. Good evening, Dr. Jitendra, and welcome to this Tricks to Preparatory course, the first webinar. And he is our core faculty from Bangalore, India, and he has vast knowledge and experience to like help the candidates to clear the EDIC 2 exam. And he would be talking about CBS, how you should be preparing, what are the high yield topics with examiner style questioning, followed by I would be describing the hotspot domains from the last EDIC 2 exam. I have gone through and analyzed what are the trends and how you should be start to preparing from now. Now followed by we have two invited faculties with us. Dr. Fadel from like Saudi Arabia. He has been trained in various countries and a very dynamic young intensivist, and also Dr. Abdel, who is also very enthusiastic young dynamic intensivist from Saudi Arabia, and he will be also be part of this like very interesting and useful webinar which is lined up. So with this background, I will be just introducing our two invited faculty. Dr. Fadel is the senior intensivist from King Abdul Aziz University Hospital, Jeddah, Saudi Arabia, and Dr. Abdel Karim, who is ICU Register in King Khalid University Hospital, Riyadh, Saudi Arabia. And Dr. Jitendra, he is the consultant critical care medicine from Apollo Specialty Hospital, Bengaluru, India. And Dr. Sanant Kumar Das, who is the consultant intensivist, and he is also the senior lecturer at the Townsville, Queensland, Australia. So with this, I would now request Dr. Sananta to start with the first important session, that is CCS.
Good evening, everyone. My name is Sanant Dash, as Tapas introduced me. Thank you for the introduction. I am going to talk about the CCS or clinical case scenario that is asked in EDIC. So as you know, EDIC 2 is a exit exam or some sort of specialty exam that makes you, or that gives you the identity as an intensivist, that you can practice intensive care as a consultant or as a specialist. So the answers expected in this exam is at the level of specialist and very to the point and very specific. The problem with the exam, or the challenge with the exam, is time. You don't have much time to think and answer because it is very time bound. The CCS is very time bound, the CBS is more time bound. So you have to be prepared to answer the things that is expected from you in that exam. If somebody starts talking about around the topic and not answering the exact point, then they will not get mark. This is a very objectively designed exam. There is a grid of answer, and if you talk about those points, then only you get the mark, even if you talk correct things. But if those points are not there in the grid, you will not get the mark. And unfortunately, sometimes the examiner do not prompt you or do not push you to get the answer. So they will be just like listening to you as if they don't have a voice to talk. And that's very confusing in that exam. So you need to be prepared and be sure that what you are answering is there in the grid. To complicate the issue more, they look at the top 4 answers or top 5 answers based on how much marks in that question is. Suppose somebody asks you about a differential diagnosis and for unconsciousness, and if you say meningitis, yes, that can be a cause for the unconsciousness, but if it is not in the top 4 or top 5 in the grade, you will not get the mark. So you have to be very accurate with your answer. Now I'll just go through in next 10 minutes a case scenario and just give an idea about what I'm talking about and what we enforce with our course to answer systematically so that you can hit the bullseye rather than talking about things that is not in the grid. That's one. Now, we'll talk about a case, a CCS case, and how do you approach, or this is suppose the case that you get in the EDIC 2 exam, and what we train you or what we suggest you to do is to scan the question and make sure that what is important in that question. This is very basic thing. You guys would have done it in most of the exams. What is important in this question, and then what are the points to be noted. But you need to go to the next step to anticipate what the question will be. For example, we are talking about this case, which is a 62-year-old female who is shifted to the ICU with shortness of breath since last 1 hour. She was admitted in hospital for fracture left proximal tibia, for which an open reduction and internal fixation was planned. She is a known case of diabetes mellitus on oral hypoglycemic since last 6 years. On arrival to the ICU, her temperature, she was afebrile, she is tachycardic, blood pressure is 102 by 56 and saturating 95% on high flow nasal cannula. She is conscious, oriented, but tachypneic at 35. Now, looking at this question, the first thing that strikes me is these things. Shortness of breath since last 1 hour. So very acute onset shortness of breath, right? So what can it be? Infection doesn't come that quickly. In an hour, you will not be short of breath. So there should be something that can cause a shortness of breath, which should be related to the fracture and the surgery possibly. It may not be related. Sometimes there is some things are given in the question to confuse, but most often whatever is given in the question is very relevant to the answer to the question they're going to ask. So they usually don't trick any candidate in the question. Whatever is there in the question is very important, and you have to find out what are the points that needs to be considered before jumping into answering. Okay. In this case, the things that stands out for me are shortness of breath for 1 hour, very acute onset, which is associated with a fractured tibia or a or if being done with it. And the patient is now tachycardic, tachypneic, and possibly hypoxic on a nasal cannula. So what are you thinking in this case? You have to think aloud. Okay, this is something which is acute, which can be due to something that has happened very quickly and that can cause acute onset shortness of breath. Okay. Anyone in the candidate or anyone in the participant want to guess what can be the next question or what they are going to ask next? There is one response. Yep. Fat pulmonary embolism. Yep. Absolutely correct. That is one of the differential. Now, you keep in mind that fixating yourself into one diagnosis is a problem. Okay. Because the next question they will ask is what is the differential diagnosis? You need to have 3 or 4 condition in your mind with the reasonable probability. Not like this patient has a lung cancer. You cannot tell that this is the first differential in this case. So there should be 3 to 5 causes that can explain such a presentation. Yes, there is one provisional diagnosis, but they can ask you what is the differential diagnosis. And if you're stuck with only fat pulmonary embolism, then you are in trouble. Okay. Yes, that should be the first one. So what is your differential diagnosis? If they ask you, make sure you have 3 or 4 causes in mind. Now, how to remember that? That is the trick that we are going to talk about. Okay. Always keep in mind that the question starts with a broad approach, like what is your differential diagnosis? You need to have 3 or 4 things. But getting those 4 things, which is there in the grid as the answer, is a challenge. Now, how to overcome that is the trick that we usually talk about in this course. Always make sure that you answer in a systematic way. Okay. When there is a presentation, we call it a syndromic presentation, there should be a differential table in your mind always. I'll talk about that in the next slide. In the whole ICU scenario, there are around 5 syndromic presentations that patient come. 95% of the cases are within that 5 syndromic presentation. We'll talk about that next in the next slide. So all those syndromic presentation have to be kept in mind, and you need to have those differentials ready before going to the exam. Now, what do you mean by syndromic presentation? One is hypoxia. Now, hypoxia is a syndromic presentation, and you need to have differential for the hypoxia practiced before going to the exam, not at the exam, because oh, this patient has acute hypoxia, what can be the cause? If you start thinking there, then you lose time, lose mark, and you will not get the answers from the grade. So you have to have a framework going into the exam ready made already. Okay, so in this case, we'll talk about that in the next slide. In this case, the first question they usually ask, what is your differential diagnosis? Now you have to keep in mind, they're asking about differential diagnosis or a provisional diagnosis. Usually in the starting, they'll talk about differential diagnosis. You have to have 4 or 5 things in there. In this case, most probably it is a fat embolism syndrome, but other differentials can be pulmonary embolism, pulmonary edema due to any cardiac causes. These are non-infectious causes, and other infectious causes can be aspiration, can be pneumonia, which is highly unlikely. Sorry for the spelling mistake there, which is highly unlikely. But at least these 3 or 4 things have to be there in your answer as a differential. Sorry. Now they are fond of asking about immediate line of management. I'll not go in detail about that. Now, what do I mean by a systematic syndromic approach? So usually there are five constellation of symptoms that patient present to the ICU. Either they have problems with your consciousness, either they are encephalopathic, unconscious, either they're weak or they are having seizures, etc. Something neurological, that's one. Number two, they can be shocked, they can have hypoxia, and they can have a low urine output. Usually 90 to 95% of the cases in the exam will be one of them. Okay, so this will be the presentation in the main stem. So you need to have a framework to have differentials for each of that in your mind, practiced before going to the exam. What do I mean by that? Suppose we talk about neurological cases. So this thing has to be in your mind, ready made before going to the exam. If they ask about, suppose the patient has encephalopathy or unconsciousness, what is your differential? You straight away think, okay, is it a central cause? It is a peripheral cause. What are the central cause? Can be infective, can be non-infective. Peripheral can be again infective and non-infective. We can go down further there. Suppose the patient comes with a weakness. Okay, what are the differential for this patient to present as weakness? Okay, whether it is a central cause, spinal cause, peripheral cause, muscle, and others. You need to have two or three causes in each of those ready made before going to the exam. If there is a weakness patient, just put those things in the right place. It will be very easy to answer. Okay. Similarly, this is one of the syndromic presentation. Suppose somebody presents with a shock. What are the cause of shock, or what is the cause of hypotension in this patient? Always make sure that you divide the shock into 4 types or 5 types and see which type the patient is. It can be multiple types in the exam. Okay. Again, patient can have a mixed shock with a cardiogenic hypovolemic or a cardiogenic distributive or obstructive type of shock. So if you have in your brain these things mapped out, it is very easy to answer the differentials. That is the first question in the exam. Okay. Suppose shock, cardiogenic shock again can be infective, can be non-infective. Infective can be myocarditis, septic cardiomyopathy. Non-infective can be causes due to drugs, vascular causes such as arrhythmia or mechanical obstruction. Hypovolemic shock can be hemorrhagic, can be non-hemorrhagic again. Then distributive shock can be septic, can be SIRS related, can be neurogenic, can be anaphylactic. So these things, these differential has to be practiced repeatedly before going to the exam so that you talk about them very easily. So combining this is the shock table that you need to know. Cardiogenic, hypovolemic, distributive, obstructive. Which one fits to this patient? Suppose this patient is shocked, then you can think of what type of shock is going on, whether he's febrile, then possibly it is septic shock or distributive shock. If the patient is bleeding, hypovolemic or hemorrhagic shock, or a combination of these two shocks. So your answer become very clear and well formed if you know these differentials in the beginning, going into the exam. Similarly, hypoxia, very common. Patient coming with hypoxia with a low saturation, high oxygen requirement. Again, every hypoxia, you have to think about not single cause, pneumonia, yes, pneumonia, but what are the other differentials? What are the other three or four they are asking in the first question? Okay, you have to keep in mind whether it is a VQ mismatch issue, whether it is a right to left shunt, whether it is a low inspired oxygen, whether hypoventilation causing the hypoxia, or whether it is a diffusion effect or a increased oxygen extraction. What are the cause? The hypoxia can be again mixed due to multiple causes. So these things have to be practiced before going to the exam. Renal failure, again, always renal failure, pre-renal, renal, post-renal. Okay, what causes this? So somebody can have both. Somebody is not drinking water at the same time has an enlarged prostate. So both can be the cause. So obstructive or a post-renal along with a pre-renal cause. So you never stop in one. If you have this pattern in your mind, then you can fully answer the grid. Okay. Now this same patient, then the third question they're asking, what are the investigation you will advise for this patient? Again, this is tricky. People give you a shopping list. So I'll do these things and these things. Yes, you can give a shopping list, but that doesn't mean anything. You have to talk rationally in the exam. Suppose for this patient, I will send bloods for complete blood count to look at the platelet count. If you think like it is a fat embolism syndrome, you can drop the platelet count. I will send a renal function test and liver function test to look for the end organ damage. I will send a D-dimer to rule out a thrombotic episode. At the same time, I will send some inflammatory markers, including CRP and PCT, to look for infection. So that's how you complete your answer. Not that I'll send full blood count, RFT, LFT, D-dimer, PCT, CRP. But why? Do you know why you are telling those things? That's what the examiner wants to know. So if you're talking about a test, then you have to tell why are you sending it. Then I'll do a ultrasound or a color Doppler of the legs to rule out any clot, to rule out a pulmonary embolism. I'll do a 2D echo at the bedside to look for right heart strain and other causes of shock. So if you're talking about one investigation, you have to explain quickly why are you sending it. Just talking about the name of the investigation doesn't give you the full mark. Similarly, what other things you want to do? I want to do a CTPA to look for any significant pulmonary embolism, and also at the same time look for signs of right heart strain. Okay. So these are the questions that has been asked. So what are the investigations? Investigation list. Then bedside echo and ECG was done, and ECG showed this finding. What is the next investigation? What you usually do is a CTPA. Then CTPA is done and no features of pulmonary embolism, bilateral pulmonary infiltrates. What is your diagnosis? So possibly they are asking about a provisional diagnosis is fat embolism syndrome in this case. Now, as I said, investigation again, what I do in my, what I tell my trainees, whenever there is a question about what are the investigation you are going to send, always think about what are the investigation group. Okay, blood investigation. What are the blood investigation? Tell them first. Then microbiological. Does this patient need a microbiological blood culture? Yes, blood culture to rule out an infection. You can tell that. Then third is imaging. What imaging you can think of? Ultrasound, echo, CT, etc., and others. So if you have a plan in your mind, you can answer all the investigation required. But if you don't have a plan or a structure, then definitely you'll miss some of them. And these questions are easy in the beginning. First 4 to 5 questions are very standard and they're very easy to answer before they go into specifics, like very narrowing down your knowledge. Now, the following question was, now the question narrows down to specificity of the presentation, like fat embolism syndrome. What are the criteria for fat embolism syndrome? So I'm not going in detail about it, but that's what you need to know. At least one of the criteria. There are different criteria for fat embolism syndrome. The commonly used one is the Gerd and Wilson's, but also there are other like Snowfield and Lindy-Quay criteria are there. But the most commonly used is a Gerd and Wilson classification or a criteria for fat embolism syndrome. You don't have to remember all those things, but at least some of the clinical things that you have to remember what are there in fat embolism syndrome according to this criteria. Uh, give a definitive treatment plan. So of course, so when they say definitive, you have to talk about what is the definitive. You don't need to talk about airway, breathing, circulation. Again, these tricks are discussed in this course. If they are asking about management as the first or the second question, you focus on resuscitation, adequate resuscitation, securement of airway, maintaining a adequate saturation or oxygenation and a circulation. Those are the initial answers if they're asking as the first or the second question. But down the line, if the diagnosis is already established and they ask about definitive treatment, you have to talk about definitive treatment, because in the grid, the marks will be about early fixation of the fracture, heparin, no role of corticosteroid, and these will be the mark fetching points. If you talk about securing the airway and having a blood pressure of 65 millimeter of mercury, the first two, they will be not in the first two in the grid. So very definitive answer, definite treatment is you have to talk about conservative management, early fixation of the fracture, and prophylactic heparin. Okay. Name two other precipitating factors for fat embolism syndrome apart from trauma. So these are all knowledge-based questions. Then comes out like acute pancreatitis can cause it, TPN can cause liposuction, sickle cell disease are other causes of fat embolism syndrome. What are the triad of fat embolism syndrome? Is dyspnea, confusion, and petechial rest. This is a clinical criteria, clinical triad. Now, first vignette talks about the patient diagnosis treatment that is given in the vignette. Now, second vignette, what happens? They usually twist it to something else. A new diagnosis, new management to see your depth of knowledge. In this case, what we have done is on day 3, patient remained to be hypoxemic, hemodynamically stable, started on heparin subcutaneous 5000 units 3 times a day. ABG shows a PO2 of 67% and saturation of 92%. Bicarb hemoglobin of 10.2, platelet count was slightly low, D dimer is still high, urea and creatinine are borderline. HRCT test done as attached. Patient complained of severe pain in the affected limb. So now these numbers doesn't look that alarming apart from the saturation of 92% on a high flow cannula, which is again acceptable. But now the new thing has arisen here. Patient complained of severe pain in the affected limb, which was not there before. Again, acute change. It did not subside even after the intravenous analgesic. So pain in an operated limb, which is a fracture, did not subside with analgesia. On examination, it is tense and decreased sensation is a problem, isn't it? What does it refer to? Any takers for this? I just wanted to show you that how the question can be twisted into different scenarios. So if it is fat embolism syndrome, does not have to talk about fat embolism syndrome the whole question. They can twist it anywhere. So if in the post-operative phase, compartment, yes, compartment syndrome, that's what it is. So now the question follows as per the compartment syndrome. So what would be the cause of severe pain? Again, they are asking for differential. Provisional is compartment syndrome, but what else can be there? There can be a DVT, there can be cellulitis, that can be acute limb ischemia also. So again, think about a few things. I know the grid will have three choices, and one of them will not be there what you are talking about, but at least 2 out of 3 you can answer. What will be the immediate investigation? Again, it is midway in the case scenario. You don't have to talk about a broader investigation, very specific immediate investigation that you do. What you do clinically is a venous and arterial Doppler. You send a CK level, RFT, urine analysis, and myoglobin to look for rhabdomyolysis. You also order for a coagulation test if the patient needs a surgery. That will be helpful. Okay. And the Doppler was abnormal, and acute compartment syndrome was provisionally diagnosed. What are the clinical criteria for compartment syndrome? Again, very clinical criteria. So pain, paresthesia, poikilothermia, pallor, paralysis. So 5 Ps or 6 Ps that we do, 6 Ps. And significant extremity pain, not responding to analgesic, tense palm compartment, but the gold standard is the measurement of compartment pressure. Okay, so that will be the next question. What do you mean by delta pressure, and what is the cutoff value for fasciotomy? So acute compartment syndrome delta pressure is diastolic pressure minus the measured compartment pressure. If it is less than 20 to 30 indicates need for fasciotomy. So that means the difference between diastolic and the compartment pressure, if it is narrowing down, that means you need to go for fasciotomy. Management for acute limb ischemia, again standard management. So start with general management. So if they have asked a general question like a management or what is the management of acute compartment syndrome, start with general management and specific management. General management includes serial examination. If there is external pressure, remove it, supplemental oxygen, analgesic, IV fluid, avoid hypotension. Specific is surgical consultation, fasciotomy. So that's, and experimental therapy later in the course, hyperbaric treatment can be considered. Now going to vignette 3.
Recording in progress.
All right. Again, they can twist this scenario into something else again. So one CCS can lead to 4 and 5 scenarios of different diagnosis and different question route. So in this case, as the patient became tachypnic, she was put on non-invasive. Lower limb swelling gradually decreased with conservative management. ICU day 5 developed gross abdominal distension, was unable to pass stool for preceding 72 hours. So gross abdominal distension, unable to pass stool. GCS is normal, bibasal crepitation, abdominal distended, tympanic on percussion, bowel sound is sluggish, last bowel open 2 days back. Investigation looks platelet count is low, rest of them are normal. Borderline creatinine, sodium is normal, potassium is very low, magnesium is 1.47, blood glucose is 242. So what's your suspicion? The question will be about abdominal distension. So what will be your suspicion here? Few people answering yes, ileus, we don't know. Ileus abdominal compartment syndrome, we don't know. Expect the bad, right? So expect badness in the exam. So it should be abdominal compartment syndrome, but if it is something else, let's see. Causes for abdominal distension, again, colonic pseudo obstruction or any other relevant pathology you can talk about. But if you say perforation or if you say abdominal mass, ascites, those are very low probability. So first one is a pseudo obstruction in this case because or ileus, because the patient is has been in the hospital for 4-5 days, should have got some opioid, and that's the most common cause for that. What is the provisional diagnosis management plan? Again, acute colonic pseudo obstruction, general management, specific management. General management includes correction of hypokalemia, hypomagnesemia, stop the narcotics, early mobilization, control blood sugar. Specific management include drugs such as metoclopramide and erythromycin, neostigmine, etc. Insertion, nasogastric latest tube, and consideration for colonic decompression if conservative management is not helping. So colonic pseudo obstruction is another scenario they can ask you. Role of colonoscopy in these cases usually not required, but can be used for diagnostic and therapeutic to rule out distal obstructive lesion if it is not getting better. And colonoscopic decompression, again, if the conservative measures are not there, then it can be used. Indication for surgery, usually not, but if there is persistent colonic dilatation even after colonoscopic decompression, if there is a risk for perforative peritonitis with large diameter of the colon, and if the patient is developing abdominal compartment syndrome, these are the indication for surgery in this cases. So that can be asked. So leave that part. We also discuss about that. Now the last vignette, again twisted to something. So always these cases, end up with a end of life type of discussion or some sort of family meeting or brain death or some sort of controversial thing, administrative controversial thing. So non-clinical administrative controversial thing, that's where they end up. Okay. So this patient was started on SLED in view of worsening metabolic acidosis and hemodynamic instability. Patient was intubated in view of poor GCS, probably septic or metabolic encephalopathy. She was maintained on 40% oxygen PEEP of 6. So she has dropped her GCS due to some reason. She was on fentanyl infusion and urine output was only 20 ml per hour since the onset of dialysis. She was on 10 microgram per kg of noradrenaline infusion. ABG shows slightly high lactate. Sodium is pretty high, 154, and potassium is 3.85. In the morning rounds, the resident doctor was happy about urine output in last 2 hours, which has increased to 320 ml per hour. For someone who was anuric, now the GCS has dropped and now the urine output has gone up. Now pupils, right side 4 sluggishly reacting and left is 2.5 millimeter reacting to light. So there is unequal pupil one-sided sluggish reaction. So what do you think what's happening here? Yeah, anisocoria, that's not the diagnosis. That's a term. Anisocoria due to what? What is what with? Yeah, something central. Somebody has written there. Again, you have to formulate the answer. Okay. The patient has unconsciousness. Think about that table. Unconsciousness, what can be the cause? Central, peripheral. Again, central can be infective, non-infective. So you should come up with 3 or 4 differential first. So stroke, hemorrhage in the brain, those can be the initial causes. In this case, I will think of, or some sort of thrombosis in the brain, because any malignancy cannot appear overnight, and infections. These are the 4 or 5 major differential in this case. So diagnosis based on the scan, there is a little bit of subarachnoid blood and there is diffuse cerebral edema. So they may show you a scan. Again, in this course, we talk about how to read a CT scan very quickly. Within 1 minute, you should be able to read a CT brain, because that's what the time frame you get for a CBS. This can be put in a CBS with a case scenario, and you'll get 1 or 1.5 minutes to read a CT scan. So CT of the brain, CT of chest, CT of abdomen, you need to practice to do it within 1 minute. So we give you some tricks and tips about it, how to rule out important finding. For example, for a CT scan, we look at 5 structures from outside to inside: skull, parenchyma, blood, midline shaped ventricular size, and any other device in it. So in this case, skull looks fine. Parenchyma, diffuse cerebral edema. Midline shape, possibly not. Ventricles are looking good in size. Blood, yes, blood is there, subarachnoid in the Sylvian fissure. And is there any devices? No. So basically, diffuse cerebral edema with a tight brain with presence of blood, possibly subarachnoid hemorrhage. That's your diagnosis. So within 1 minute, we should be able to read the CT brain. All right. So in this case, differential diagnosis, diffuse cerebral edema, possibly cisternal subarachnoid hemorrhage, immediate plan of management. So for this, you need to talk to your neurosurgical colleagues, hypertonic therapy to decrease the pressure, and other neuroprotective strategies. Now, one of the family members asks you about the outcome of this patient. How will you explain? Again, this is a very, what do you say, personal assessment. The examiner will tick off few things in the grid, but we'll see how you are explaining. If it is according to a structure that has been given in literature, then you pass it easily. So there are different ways of doing this type of counseling, the spike protocol or solar protocol. In this case, I have my ways of saying the answer so that I can mention all these points that will tick up the boxes, right? So I will create a adequate setting, making sure that I have my colleagues such as social worker with minimal distraction and allowing the patient relative to sit. I will assess the pre-knowledge what the patients have and pre-perception what the patient's relative has. I'll talk with empathy, okay, and then I'll explain the facts and help it with some documentary evidence if the family wants for it. and I'll invite questions from them. Then at the end, I'll summarize my finding to the patient relative and make sure that they have understood the discussion. Okay. Now this is the structure. That's how you are going to talk. But the content of the structure, the content of the discussion you have to put in. Like in this case, the family asked about the outcome. So you talk about the outcome looks poor. So I'll make sure that the patient relative is sitting comfortable. I will assess what he knows about the patient and what's his perception. Then I will be firm in my discussion saying that this is a poor outcome or a poor development that the patient has. We are unsure at this moment, and we will have some more time to be given to the patient to see the outcome of that. And we have asked our colleagues to consult on him. A neurosurgical colleague will have a look and will give you more idea about it. And then ask or invite questions, whether they have understood the discussion or not, and invite questions. So if you tick up these points, then you will get the full mark. All right, so I'll stop here because I'm not going to go through the whole CCS. But as I said, you have to practice these things. I know all of us work in a ICU which takes care of patients in a good way, but the exam scenario is slightly different. The expectation in the exams are different, so you need to be a little bit artificial in your approach and practice. All right. I'm happy to take any questions if there are. Otherwise, I'll hand over to Tapas to carry on.
Yeah, thank you, Dr. Sananta, for diving into the details of the CCS and also sharing the tips and tricks to like score maximum.
Good evening, friends. I think you've made yourself free and been part of this discussion since last half an hour. So another 15-20 minutes, I'll be taking you through the next part of the EDIC 2 exam, that is your CBS, that is computer-based scenario. Professor has already introduced me. My name is Dr. Jitendra. I'm a senior consultant at Apollo Hospital, Bangalore. And so without wasting much time, we'll go into the exact topic, that is CBS. So CCS has already been discussed by Saran sir. So now it will be computer-based scenario, that is CBS. As Tapas rightly said, I have also been talking to a few people who took their exams this time. And the feedback was CBS was a little tougher compared to CCS because the questions were lengthy and they found it a little difficult. And as said, it is very specific answer they're expecting, and we have a very strict time frame. And as already told, in EDIC 2 exams, you don't get any feedback actually from the examiners. Very rarely get some feedback. Otherwise, it'll be like once the time is done, they'll be changing to the next question. So in CBS, we'll have 3 stations, approximately 12 minutes in each station. And it is specifically divided. So in CBS 1, you'll be talking about ECGs, ventilator waveforms, other monitor waveforms on the monitor, or most of the waveforms will be covered in the CBS 1. CBS 2 usually has some radiology like CT scans or X-rays, so which we'll be picking it up. And CBS 3 will be about biochemistry and blood gases. This is how it is specifically designed. And in our modules also, when we are part of the EDIC 2 preparation, we will also be discussing CCS and CBS and how to approach them during our original exams. Okay, last year, the last exam which people took in the month of November 25. So these were the questions which were asked, which was shared by a few of my friends. So they had ECG, so most of it was discussed about hypothermia, ECG changes in hypothermia, inferior wall MI, and the non-standard recording, which will be having a question in our mock also. Usually discussed our IABP waveform, ETCO2 waveform. ROTEM is a question which will usually be asked. So every exam you definitely get a ROTEM. It may not be in the CBS, can be part of the CCS also. So you get a patient that's with sepsis, next you get some coagulopathy, they'll be asking for ROTEM, or you can get a question in CBS 2 on ROTEM. You'll be asked about CRRT, like citric overdose, So coagulopathy will also be a question in that, as I said, ROTEM can be part of the coagulopathy, or it will be like DIC or sepsis like that. Other frequently asked questions are thrombotic thrombocytopenic purpura and tumor lysis syndrome. These are very high-yielding topics. Usually, year after year, these do get repeated also. Okay, so after briefing you about the CBS, as I said, it is very time-bound, 12 minutes each station, approximately 90 seconds for one question. And we'll see a few questions as part of the mock. And here answers are expected very specific. You don't get a vague question like what are the differential diagnoses, So it will be very specific case scenario. Though my mock has very small questions, but usually in the exam have pretty big questions. So this is how it will be. So this is the first question among the mock exam. So the question is: a patient with triple vessel disease undergone CABG post-op, put on mechanical ventilatory assist device. So the question is: identify the device and identify the abnormality. So you can see the chest X-ray on the slide. And here they'll not be asking about the what are the findings and all. See, the question is very, very specific. If it was CCS, they would have asked you what are the findings, read the chest X-ray like that. But here it is very specific. So they have asked you to identify the device. Anybody wants to take this question? So you can post your answers. So, so I think somebody's posted, noted. So anybody? What's the mechanical circulatory assist device which you can see on this chest X-ray? Anybody? Yeah, I think most of you picked somebody's told ECMO. No, it is not ECMO. So as you can see here, you can see the tip of the IABP balloon, and you can see the inflated IABP balloon on this chest X-ray. And they asked you to identify the abnormality. So second part of the question, anybody wants to take? What is the abnormality you see here? Yes, anyone? So yeah, so one of you, I mean, one of our faculties only told the answer. Any student want to attempt it? So, so I said it is not ECMO, it is IABP cannula. Okay, so the other one is the sheath. Okay, that is not the IABP cannula. So, okay, this is, I mean, sorry, this is IABP and the inflated balloon. And you can see the tip of the balloon is at the, I mean, it is almost crossing the aortic arch, correct? So, this is not the ideal position. It is too high. So, that is the answer. So, abnormality is that this balloon is positioned too high. Ideally, it should be positioned in and around the carina. Okay, at the branching of your left main bronchus. So, that is where it is supposed to be, but this has gone beyond that. So, it is a very high position of your IABP balloon. So, that is the abnormality you see. Okay. IABP and IABP tip is displaced upward, so you will have to reposition it. So this is the answer for this particular question. I told you it is very specific. So IABP is the answer for the device, and tip is displaced upwards. So it is gone to inside, so you'll have to pull it up and position it at the level of the left main bronchus. So other hardwares is a very favorite question on the X-rays. So I'm not going to details of this. So next question is, so this is again about biostatistics. So the question is identify the image and what is the significance of the square shape. So anybody wants to identify the image? What is this biostatistics? Yes, anyone? This is no real exam, so you can take your chance. Yeah, two of you said forest plot. Somebody said drug level. No, this is no drug level. No. So this is a forest plot. Okay, so this is comparing anastrozole with tamoxifen. Again, biostatistics is also a favorite CBS topic. So what is the answer? So this is forest plot. And the next question which I was asked is, so what is the significance of the square shape? Yes, what is it? When answer is already there. So the square shape determines the size of the sample. Okay, so the size of the study or weight of the study, whatever we call, the size of the square. If it is this study, which is very small, indicates that there are only small sample size, whereas the one which is very big indicates that this study has a very pretty good amount of sample size and it contributes significantly to this meta-analysis. Okay, so that is how it is. So position of the square is the point estimate of the odds ratio. So this is the odds ratio. So 1. So what is the position of the square? Tells us how close it is to the results. I mean, that's how it is. Okay. So other graphs are also usually asked during your CBS questions. So the commonly asked graphs, I mean, this is how you read this forest plot. So you have a vertical line which is then at the center, so which represents the odds ratio of 1. That is no effect. So if something crosses this, that means that that particular study is not having an effect. You can see this line which is crossing, that has no effect. These three studies say that they don't have any effect. That is, the results were neutral. Okay, so whereas you see one of this study which is coming onto the left side of the vertical line indicates that this is something significant. Okay, so it favors the results on the left side of the odds ratio. That's what it means. So I told you the position of the square is the point estimate of the odds ratio. And I told you the square size indicates the weight of the study according to the weighing rules of the meta-analysis, likely representing the sample size and statistical power. So this tells about the study. And diamond is final results. So what did all these 4, 5 studies do? I mean, the final results of all the studies together is your diamond. And it will also be positioned based on what is the final results of your meta-analysis. So the diamond represents the combined results of the trial The results of statistical significance if the combined results do not cross the vertical line of no effect. So if this diamond also crosses, then it means that it has no significant effect. Okay. So this is how you will be asked in an exam also. They'll ask you to identify the biostatistic graph and then interpret the graph also. So these are other graphs which you can be asked in your exams. Kaplan-Meier curve is pretty frequently asked. ROC curve sometimes, and others are like scatter plot, bar chart also may be asked. Okay, we saw a curve, we saw X-ray image, another CT scan image, and of the abdomen. So again, we'll not be asked to describe the finding in detail. So this is the detail of the case. So a 78-year-old male who is a diabetic who came to 24 hours after an anterior resection with anastomosis of the rectal, sorry, one second. So rectal neoplasm showed sudden pain among the soft tissues of the right flank and fever. So interpret the image. So here they asked you to interpret the image. And what is the further line of management, and do you know any scoring system? So then I'm getting some answers. So yes, somebody said the necrotizing fasciitis and the score is LRNEC. So what is the further line of management, and interpret the image. They have asked you to interpret the image. You have just shown necrotizing fasciitis. You should, tell a few findings why you say it is necrotizing fasciitis. The diagnosis is correct, necrotizing fasciitis, but they've asked you to interpret the image. So when I've asked you to interpret the image, you should tell you why you say it is necrotizing fasciitis. Okay, so you can see this is a plain CT scan of the abdomen, correct? So you can see it is seen at two levels. So one is at the level of the pelvis, the other one is little higher up. And you can see there is some very prosthetic material, probably a drain or something. And you can see there is air pockets in the subcutaneous plane. And there's significant air pocket little higher above also. So this is what is the finding you see in this particular CT scan of this particular patient. So what is the answers for this? So as you said, this is necrotizing fasciitis. So coming to interpretation of the CT scan, there are air densities and collections and significant edema extending along the soft tissues as right subcutaneous fat tissue, parietal abdominal muscles, and subcutaneous fascia. You can see air is there in all the planes. So what is the management? And your diagnosis is correct, necrotizing fasciitis. Obviously the management, immediate surgical debridement of the involved tissue, antibiotic cover, with hyperbaric oxygen can also be considered as an adjunct to surgery and antibiotics. So it is a very crisp answer. So your interpretation of the CT scan, what is your diagnosis and how do you manage this case? So antibiotics, surgical debridement, and hyperbaric oxygen as adjunctive therapy. Okay. So this is the LRI-NEC score. This is there for necrotizing fasciitis anywhere in the body. This is the score. So laboratory risk indicator for necrotizing fasciitis. They are found of pretty, certain scores like a few scoring systems in your pancreatitis, scoring systems in necrotizing fasciitis. They are usually as for any soft tissue infection you get, ultimately we'll be asking you about this score. So you should know about this score, that is LRI-NEC score. So it has parameters like CRP, WBC, hemoglobin, sodium, creatinine, and glucose. And the total score will tell you the risk which is associated with this. If the score is less than 6, it is a low risk. So 6 to 7, it is intermediate risk. And if it is more than or equal to 8, it is high risk. Okay. So coming to the next question. See, again, this is a little India question, but you will not get panicky after seeing this question. So you just wait for the details. So a 30-year-old male with head injury was on a ventilator. So he was withdrawing from painful stimulus. His pupillar responses were equivalent. Brain CT scan showed bilateral frontal contusion and subarachnoid hemorrhage. His blood pressure was 100 by 60 millimeters mercury, and SpO2 was 93% on 0.6 FiO2. His temperature was 100 degree Fahrenheit and blood sugar was 70 milligram per deciliter. He had been nursed with the head elevated at 45 degrees. The ICU doctor has decided that the patient requires a central line and has approached the wife of the patient for informed consent. She is apprehensive about the possible complications and wanted to know if you can avoid the invasive procedure and about alternatives. So this has nothing to do with the case scenario. So mostly it is a lengthy case, so you need not get frightened seeing the length of the case. So it is mainly discussing about the ethical things in this particular, ethical principles in this particular case setting. So anybody wants to take this answer? So you plan to put a central line and your ICU doctor is supposed to communicate this to the patient. So what are the ethical principles which are involved in this? And the wife wants to know what are the complications and the alternatives which are involved in this particular procedure. So what are the ethical principles involved? So you all know the four basic ethical principles which are there, correct? So what are the ethical principles involved in this? So one is your autonomy, beneficence, non-maleficence, justice. So what do you think is involved here? I don't see any answers. So let us go to the answer. So one is about autonomy. So you are giving informed consent and asking the patient's wife, because patient is not in a condition to give a consent. So you're talking to the patient and you're talking to and taking an informed consent. So this is about, you're talking about autonomy, and you are discussing about minimizing the risk and keeping patient priority, I mean, not causing any harm to the patient. So non-maleficence. So that is what non-maleficence means. So you're not causing any harm. You're doing good to the patient and you're giving them informed consent. You're telling them the alternatives. You're telling them what are the complications you are expecting in this particular case. So the two ethical principles which are involved in this particular case is autonomy and non-maleficence. So, 32-year-old, next coming to the fifth CBS question. As I told you, they are fond of images. A 32-year-old primary gravida underwent normal but prolonged labor for 38 weeks of gestation and gave birth to a child. 1 hour later, she complained of sudden shortness of breath, severe anxiety, chills, and vomiting. Her vitals are BP of 78 by 56 millimeters of mercury, heart rate of 126 per minute. SpO2 was 92%, respiratory rate of 28 per minute. 2D echo is done. So what is the diagnosis? So anybody wants to comment on this 2D echo finding? So first of all, what is this 2D echo image? So, I mean, we already got the answer. What is the likely diagnosis? Absolutely. So two of them have given the right answers. So it is amniotic fluid embolism. So it is seen in the immediate post-delivery period. So it is a case of amniotic fluid embolism. So we discussed this in our CBS in the previous obstetric module when we discussed for the previous batch. Okay, this question was discussed. We had discussed in detail about management of amniotic fluid embolism. So this is that case. So it would have facilitated who had attended our course in the previous term. So you can also see this is a typical four-chamber view. So you can see that your R and RV is dilated. Okay. So what is the likely diagnosis? Most of you are told amniotic fluid embolism. So next question is, how do you treat shock refractory to inopressors? Yes. So that also somebody has already answered. So this is a case of amniotic fluid embolism. You see there is significant shock, is already some vasopressors, inopressors, and the next choice, if it is not improving or if it is refractory to your inopressors, is to start him on VA. Okay. So again, so ventilator graphics and ventilator settings. So this is a case scenario. So this is a 54-year-old previously healthy male was admitted to the ICU after 45% total body surface area burns. He was admitted to the ICU within 1 hour of injury in shock state. He was intubated and fluid resuscitation started. Peripheries are pink. His hemodynamics are worsening with rapid rise of vasopressors. 20 minutes later, an ABG is done. So okay, ABG shows pH of 7.25, PaOut of 96, PCO2 of 38, bicarb of 15, and lactates are 14. Sodium is 152, potassium 4.6, and chloride 114. Current ventilator settings are FiO2 of 1 on assist control mode of ventilation, tidal volume of 480, respiratory at 28, and P 10. So what do you think? So what are the key catchy points here are surface burns 45% within 1 hour of admission. Peripheries are pink, so intubated and fluid resuscitated. Okay, so and requiring some vasopressors, and you can see on the ABG also there are lactates of 14. So and he's requiring FiO2 of 1. Okay, so let me see the answers. Somebody has asked if the webinar is recorded. Yes, it is recorded. Okay, so I mean somebody said cyanide toxicity. This. Okay, so burn shock secondary to cytokines with ARDS. Most likely you can see the peripheries are pink and your patient is shocked, but the worsening vasopressors and lactates are high. So all this goes in favor of cyanide toxicity. So burns patient, severe hypoxemia, vasopressors, pink peripherals, and high lactates. So all this goes in favor of cyanide toxicity. Okay. So supportive treatment, so decontamination and management as well. Have specific antidotes to it, either hydroxycobalamin or sodium thiosulfate. In our previous modules, we had a discussion on similar case, but we had discussed about carbon monoxide poisoning and we had given a differential as cyanide toxicity. So during our previous weeks. Coming to the seventh question. So this again, as said, favorite CT finding. So a 24-year-old female with polytrauma was improving, but on day 20 of her ICU stay, she developed new onset sepsis. CT abdomen was done on the basis of suspicion. So what is your diagnosis and management? So what are you seeing on the CT? So what is the diagnosis and management? Unless what is in the CT, they're not asked. So if it was a CCS, I would ask you about detailed discussion. Somebody said calculus cholecystitis, but there is no calculus there, correct? So yes. So it is acalculus cholecystitis. There is no calculus. So all of you can see there is GB wall edema, but no calculus. Correct. So there is no calculus. So no hyperintensity is seen there. Okay. So this is a case of acalculous cholecystitis, and this management, we all know it is conservative management as a percutaneous drainage. So based on the patient's symptomatology, how is improving, how are the hemodynamics and stability, so we plan on the conservative management or percutaneous drainage, put a pigtail into the bladder. Again, another monitored graph. So comment on the arterial tracing. How will you confirm your observation? Yes. So what is your finding? Yes, somebody is answering. So again, don't be non-specific like damping, you should be very specific. They're asking you what is the finding. You should either say over damp or under damp. So all of you know it is over damp, correct? So you just saying damping, again, you may not get the marks because this is CBS and they're expecting you to tell very specific answers. And how do you confirm it? Next part of the question. So it is over damp, and what is the square wave? Yes. Fast plus test, yes. So over damped arterial tracing, confirm the fast plus test or dynamic response tense. I mean, as next extension, maybe they may change the question also. They may ask you what is the findings and what do you see on over damped arterial tracing. That can also be a question. So this is you only get two questions, so this is what they ask. So maybe next time they can ask you what is the arterial trace and what will happen to the systolic and diastolic blood pressures if it is a over damped tracing. So something like that can be asked. Go to the next question. So 35 years female, uneventful pregnancy. In postmortem, sudden onset of severe headache, neck stiffness, bilateral visual changes, ophthalmoplegia, brought to the ER in hypotension. So blood sugar levels were 56. MRI brain was suggestive of cellular hemorrhage. So what is the diagnosis and management? Very specific question. So what do you think is the diagnosis? Sheehan syndrome, steroids, surgery. So when do you think steroids? When do you think surgery? Answer is correct. Sheehan syndrome. Post uneventful pregnancy, sudden onset ophthalmoplegia, visual changes, and MRI showing cellular hemorrhage. So when steroids and when surgery? Okay, somebody had answered it correct. So this is a case of period apoplexia, Sheehan syndrome. So management is high dose glucocorticoids if no visual impairment. But you saw this patient had some visual symptoms. So if it is visual symptoms, you need surgical decompression because that blood clot is pressing on your optic nerves. So you can't just wait with giving steroids. So if there was no visual impairment, the answer was only high dose glucocorticoids. Because there is visual loss or visual worsening or visual symptoms, then you should consider urgent surgical decompression to relieve the pressure on the optic nerve and the chiasm. So last question for the day. So this is the ECG finding. So a 32-year-old man was presented with complaints of fever and dry cough. ECG was done as part of initial evaluation. So what is your ECG finding and what is the differential? Anybody? What are you seeing in this particular ECG? ECG is also very, very favorite. As I told you last batch of EDIC 2, they asked 3 questions on ECG. And just see the answers. Okay, upright AVR. The last two ECG findings is upright AVR. Okay, wrong leads. Okay, that is a difference. They have asked you differential, so I've only got one differential. So is it only upright AVR? Anything else other than upright AVR? Okay, differential. Another differential. What is the differential for? Okay, so again, so this may be the reason why students say we attempted everything, but yeah, poor RV progression is other finding. Another differential dextrocardia, correct. So this may be the reason. So you say only part of the answer they were expecting for another answer. That is why people feel that they have answered, but still they could not get or they could not clear their exams. Okay, so let us see the answers. So this is There is no RY progression if you had seen it on the ECG. So the differentials is either lead reversal or dextrocardia. So how to know that? So if there is poor RY progression, so it is usually dextrocardia. Whereas if you see lead reversal, there is only problem with the lead. Okay, there is no problem with your cardiac activity, you know. So usually you see a good RY progression in case of lead reversal. Whereas if you see there is poor RY progression, then it is most likely to be dextrocardia. Okay. That's it. So we have just, I just briefed you how an exam looks, what are the questions you can usually expect. So this is just a mock exam. So just for you people to have a feel of it. So I can take any questions. If there are no questions, I think we'll go ahead with our next presenter.
Thank you, Dr. Jitendra. This was again very crisp and to the point. And as you rightly told in the last question, candidates were very particular about the answer, like lead reversal. Somebody has told dextrocardia, but you will not get the full mark. So that is the thing that we need to practice, and we need to practice it regularly, frequently, and to be very attentive when you listen to any question. Don't just jump to answer it. Maybe a 5 second of pause, thinking in your internal wearing in your neurons, and then answer it in one go. So that would be helping you to face the full mark. Otherwise people say that we have all answered, but why the result is not showing or reflecting the our efforts. Yeah. So thank you, Dr. Jitendra, for your time as well as your efforts. And with this we will be going with the third one, which is my domain. And this is something very interesting. I have actually analyzed the last recall questions from various candidates who have appeared the last EDIC 2 from our batch, our academy. And I have tried to actually get the gist out of the CCS and CBS question. And believe me, the trend is very surprising. Now the EDIC 2 exam is very uh, particularly focused with the clinical reasoning. They don't want to just mug up with all the guidelines and the points in the A B C D, something like that we normally have learned in our training period. No, they are very particular. So I will be next maybe 10 to 15 minutes, I will try to uh, clarify the myths around the CCS and CBS, and how the recently conducted EDIC 2 exam have actually asked the CCS and CBS questions. These are only the recall questions, and people have shared the questions from their memory. So there is no guarantee that these questions were exactly asked in the EDIC 2 exam. So this is disclaimer from my side. Okay. Now I would be trying to share some of the high-yield questions, model answers, and examiner traps that we need to be very, very clear. They would try to ask you something which you may not understand with their sentences. Maybe the question will be written in some other way and you are thinking in some other way. So maybe though you feel that you are answering it confidently, correctly, but the examination is not going in that direction, or the examiner is not happy to give you the full mark. Now, why these CCS stations matter? This is the EDIC 2 Trend 2024-25 multi-system CCS. Now, every CCS that has been asked in last 2 years, I would say, they have started with a single clinical scenario or vignette, but that has actually entered into a progressive deterioration of that clinical case. They have focused on early recognition, respiratory failure decisions, some or other, because this is part and parcel of our critical care practice. So they would definitely end up with patient started with pneumonia. Now patient saturation is SpO2 is falling. So how you are going to tackle those important deteriorations in the ICU? They are now sharing with you something clinical scenario which is having a prolonged ICU issue. That means the patient is in ICU. So how you are trying to deal with all those complications that happen during the ICU stay? Maybe that is not the primary pneumonia or respiratory system problem, but maybe this is something related to Clostridium difficile diarrhea, maybe something related to central and associated bloodstream infection, maybe something related to intracranial hemorrhage. So how you are dealing with that? And also the most important thing that has actually right now coming into the examination in last 2 years observed by us is post ICU outcome. Now they are very particular about how you all are actually managing the post ICU outcome, because the ICU care does not end with only shifting the patient from ICU to HDU or to the ward. That also like your responsibility to deal with some or other complications, post intensive care syndrome, all these things. So definitely these are something hot CCS domains those were identified. Now in the last exam, 4 hot CCS domains those were identified. I would share with you one by one. So this is something for the first time, so please focus on the following slides. They have been curated for like each one of you, so that you will be confident enough to start preparing from now only, that yes, this is the label of EDIC 2 currently, and how we have to like know the strategy to conquer the exam. The one case that was asked CCS was GBS with respiratory failure. Very practical, very standard question. But yes, there are a lot of like in between those clinical vignette questions, sub questions. Those maybe if you do not know, you will not score well. Second CCS was undifferentiated shock leading to ARDS and some or other like the different other complications that is asked. Now the third one, very particular, in the last, like the EDIC also, in the May session, they have also asked about HLH, hematophagocytosis, lymphocytosis, histiocytosis. And this is like the confusion was with the sepsis. So HLS plus minus sepsis, that was the third CCS. Now the fourth one was post cardiac surgery shock plus some or other pacemaker issues, pacing issues. Okay, these are the 4 hot CCS domains identified. And just one like a message that I want to share with you, examiner wants reasoning, not listing. This sentence is very important for all of us to understand. They don't want that you will be just like sharing differential diagnosis 1, 2, 3, 4. No, how and why you are saying that. They also want the reasoning. So that's the reason why we need to be very clear in our concepts. Why we want to answer those in the examination. Now the first one, GBS with respiratory distress, I would be only sharing the salient points about that CCS, because we have already covered similar the free recall webinar like class on December 6th. I'm not repeating that. Now the key clinical clues that have been asked in the exam, acute flaccid paralysis. We all know GBS is one of the most important clinical differential diagnosis for the acute flaccid paralysis. Patient presented with upper respiratory tract infection prodrome. There was rising CK, creatinine kinase, CRP, and WBC. Rapid desaturation happened in that patient, and they also asked about the differential diagnosis of acute flaccid paralysis. And we all know you have to be thorough with the first differential diagnosis, which is the case itself. But yes, there are also some other differential diagnoses of acute flaccid paralysis in the form of myasthenia gravis, transverse myelitis, botulism, spinal cord infarct, periodic paralysis, alcoholic neuropathy. Now, here the clue is examiner checks the pattern recognition. They would be sharing with you some of the clinical clues, but how you are actually making all those clues in a proper way. That is the essence of the practice. If you have already practiced it in your clinical the domain, and also in some or other courses that normally we offer in our TRICS 2, then only you can immediately know it in the exam stress. Otherwise, you will not be able to actually figure out what is happening in the real that exam environment. Now, in the examination, they asked about the bedside criteria for early intubation in GBS. Now, you must quote some numbers. And here, the 20, 30, 40 rule you have to remember. Vital capacity less than 20 ml per kilogram, negative inspiratory force less than minus 30 centimeter water, and respiratory rate more than 40 per minute, along with bulbar weakness and rising PaCO2. So these are something If you are getting, definitely you should be intubating the patient early in GBS. Now, the important point about airway management. Now, just look at the question. They have started with GBS, which is a very fundamental, clinical case that we normally practice in our clinical the training. But they are also checking how you are confident or how you have actually grasped the basic knowledge about the airway management in GBS. Now, they have also expected that you should be knowing rapid sequence induction in GBS and what are the key points that are actually important in the GBS. One is pre-oxygenation in mandatory, avoid succinylcholine, which can lead to hyperkalemia, and GBS patients are notorious to have autonomic instability. So during this intubation, you have to be prepared with vasopressors and atropine to be ready because these patients are very prone to have bradycardia and sometimes asystole also. Now, 20, 30, 40 rule almost always tested in our the regular clinical training and also in this type of high competitive European Diploma of Intensive Care exam. Now, if you have been asked again GBS, because GBS is more or less frequently asked CCS type in your European Diploma. Believe me, when I have appeared this EDIC 2, there was one case CCS on GBS. And so it is a very regularly seen CCS. So NIV in GBS, examiner trap. So they would be asking whether you want to try with NIV. So you should know why NIV usually fails. Respiratory muscle fatigue, bulbar dysfunction, and secretion clearance poor. Now your answer style should be always try to frame this type of sentences in the exam, and this would be impressive, and the examiner would be also very happy to know that yes, I can give him full mark. Like NIV may be attempted in very early disease without bulbar involvement, but low threshold for intubation. Now here you are playing safely. You are also trying with NIV in the initial time, but you are also letting the examiner know that you are concerned with the bulbar involvement and also low threshold for intubation. This is the the beauty of the preparing it well beforehand. Now, never strongly advocate NIV in GBS, and we all know the reason. Now, investigations and disease specific, something right now the examiner may ask you, and they have actually asked in the last EDIC 2, MRI spine that exclude maybe transverse myelitis, spinal cord infarction, NCS EMG we routinely do in GBS, demyelination, CSF. Yes, we all know cytoalbuminologic dissociation, but in the exam you should be mentioning these things very promptly. Now, role of plasma exchange, that is therapeutic plasma exchange. Yes, the indications would be non-ambulatory and ventilated patients. They need large bore access, calcium monitoring, complication you need to remember. Again, is there any evidence of therapeutic plasma exchange plus IVIG together? Most probably no. There is no added benefit, rather it can increase the complications. So something you need to be very clear if you are getting a GBS case in the CCS. Now, the second one would be at the end, why you need to go with early tracheostomy and what is the indications of that. Now here I have only narrated the tracheostomy advantages that you are expecting prolonged mechanical ventilation, again secretion clearance, and also putting the patient on long-term sedation. So all these things can be obviated with early tracheostomy. Now, what are the common mechanical ventilation complications? We all know, and what are the winning readiness? You have to be be confident so that you can start weaning the patient from ventilator. So mention sometimes now the bedside point of care ultrasound, mention diaphragmatic ultrasound if you are getting hemi diaphragm elevated in this type of patients in chest x-ray. Now the second CCS they have asked post cardiogenic shock or maybe a case with undifferentiated shock. They have tried to ask, and you won't believe they have also included ARDS in that. So the shock differential are septic, cardiogenic, and hypovolemic. And they have also asked about the sepsis bundles. Say sequentially, that is the clue. Though you may like say anything out of these 4 points, but it should be starting with cultures, followed by antibiotics within the first 1 hour, the golden hour. Fluid, again the balanced fluid, which is the choice. Vasopressors, lactate clearance. Maybe these words are the buzzing words. You don't need to explain in detail. The examiner, they understand that yes, you are a very seasoned intensivist trainee and you have already worked in like your ICUs for maybe through 2 years, 3 years, 5 years. So you can only tell about the the important words and they can understand to just save the time. Now the question also was asked ARDS oxygenation strategy in severe ARDS, and yes, this should be at the tip of your tongue. If you are asked again in the upcoming exam, you should be finishing this in maybe 10 seconds. And the words should be lung protective mechanical ventilation, prone positioning, neuromuscular blocking agents, early severe ARDS. Now everybody knows it is not the accuracy trial, which is now also proving to be of so much of essence. Now the Rose trial and the recent meta-analysis, they have not given the clear verdict of using neuromuscular blocking agents for every case of ARDS. Restrictive fluids, permissive hypercapnia, inhaled nitric oxide, which is a rescue maneuver or therapy. There is no mortality benefit. That also you need to remember. Now, the third CCS I have already told, HLH disguised as sepsis. And some of the red flags that we all know, they have given the clue for persistent fever, cytopenia, high ferritin, high anion gap metabolic acidosis plus lactic acidosis, and organomegaly. Now, the HLH 2004 criteria, if you are getting HLH in any of your clinical exam, definitely they would be asking or expecting you should be mentioning at least 5 or more than 5 criteria: fever, splenomegaly, cytopenia, hypertriglyceridemia, hypofibrinogenemia, ferritin to be very high, decreased NK cell activity, and bone marrow hemophagocytosis. Remember, it's not that HLH and sepsis cannot exist together. Yes, they can coexist together. That also you need to remember. Now, the management and prognosis, yes, confirm the diagnosis by bone marrow biopsy, ferritin level, and soluble IL-2 receptor, which is soluble CD25. Now, the management, we all know, first you have to treat the trigger, infection or malignancy, steroids, etoposide, IVIG, and multidisciplinary therapy approach. There are certain poor prognosis indicators. They have asked about that also. Malignancy associated HLH, definitely that would not be that much type of sensitive to our usual therapy. HIV plus B cell lymphoma, and if your patient is not having response to steroid, that is also a poor prognosis indicator. Now refractory disease, you have to go ahead with hematopoietic stem cell transplantation. Now the fourth case, the CCS, they have asked post MBR, patient was in shock and there are certain pacemaker issue. And in this, they have asked about to evaluate the shock post cardiac surgery with bleeding, cardiogenic shock, vasoplegia, maybe obstructive shock, and they have also asked about the temporary pacemaker setting. This is one of the most important domain that we are now observing. In any critical care exam, they are expecting that you should be thorough with the pacemaker settings. And happy to share with you, we are coming up with a separate class, or I would say a video on this pacemaker, where we will be sharing with you all the details how to solve the different clinical questions in the ADL exam. Now, in the exam, they have expected the answer to be mode, rate, output, sensitivity, and in the exam case, there were also certain questions on the hiccups in the patient where the pacemaker was there, and what were the causes of hiccups. So it could be phrenic nerve stimulation, lead malposition, some of the diaphragmatic pacing could be also one of the reason for the hiccups. And most important parameter to check in case of pacemaker issue is the lead position and pacing output. Now, in the last related to the CCS, the success formula, what I can think about is pattern recognition. The examiner expect that you are a the consultant level or attending level trainee now. You are no more a first year or second year trainee. So you need to recognize the pattern, rapidly identify the clinical syndromes and phenotypes. Second one, early decisive intervention. So quickly you are stabilizing the ABC, immediately don't deter. Now, the third one is anticipate ICU complications. So proactive harm prevention. This is something as per the ethics also. And final, always think post ICU. Focus on the long-term functional outcome and ethics. The examiner is testing the intensivist you will become. It's not like how you are right now doing as a trainee. They expect that you are the future intensivist. So they want to be on the safer side. Yes, if I am qualifying this candidate, he or she is going to actually cure so many patients in future. Okay. Now, maybe 4 or 5 slides more. This is related to the CBS. What was tested, why it was tested, and what will repeat. Again, I am not playing here with a crystal ball, but what I can guess from like our last 3 years of experience, key EDIC to shift in last maybe 2 to 3 exam. They are now not expecting to share the image and expecting the diagnosis. Now they want to get the decision making CBS from all of you. So let's name the diagnosis. You will not get a question, or maybe frequently you will not get a question with name the diagnosis. More, what kills the patient next? What do you do in 5 minutes? What complication are you missing? This should be the trend of questions. Now we are getting the feedback. Now, don't take the radiology questions as radiology viva. They are not expecting you to narrate the 1, 2, 3, 4 findings. Rather, they are expecting that you are working in an ICU and how you are thinking under the time pressure. And that is actually what is happening with the candidates who are actually giving feedback for the CBS. So they are saying we know everything, but we cannot reproduce it in the real time pressure. And that's why you have to practice, make your reflexes sharper. Now, one was the acute hypoxemic respiratory failure. Multiple times these type of questions were asked, and I have already given you in the CCS also. They can create this type of clinical vignette, like elderly patient with hematemesis now presented with hypoxia, trauma patient, day 2 patient deteriorated with acute hypoxemic respiratory failure, pneumonia with ventilator waveform abnormalities. So now what EDIC is testing here? Rapid pattern recognition on the chest X-ray on the ventilatory screen, and how you are able to distinguish ARDS from aspiration, from pulmonary contusion, from atelectasis. So they also expect how we are immediately doing the action like oxygen, airway, and the ventilatory strategy. So definitely the question would be, what is your immediate ICU action? Showing one chest X-ray or CT scan, something like that. Now the second hot domain was post cardiac arrest neuroprognostication. Multiple times this type of questions were asked in the CBS, again one of the clinical vignette of the CCS also. So the examples of the question, day 3 post out of hospital cardiac arrest, patient is comatose, no spontaneous breathing, and CT brain shown. Examiner would be focusing on global cerebral edema, loss of gray white matter differentiation, and effaced sulci. Clear? Now the key AD concept, believe me, this would be again coming in the next exam. I can bet it. Prognostication timing, avoid premature withdrawal of the life support system, and multimodal approach, CT, EG, exam time. And the examiner expect your answer should be having this phrase. This suggests severe hypoxic ischemic brain injury, but prognostication requires time and multimodal assessment. Something the examiner would be very happy, and he or she will feel that yes, this doctor is somehow making sense in this type of complicated and sensitive case. Now, multiple questions were asked about the winning failure and spinal pathology, and they can show you MRI spine in this case, or maybe they would be expecting to recognize cervical spinal cord injury, cord edema, compression, diaphragmatic weakness, and permanent ventilator dependence. So structural causes of weaning failure, not just ICU weakness. So they are not expecting you to be only going with the ICU acquired weakness, critical illness, polymyeloneuropathy. No, they may be dealing with something out of these differential diagnoses. Now, hot domain 4, trauma related respiratory deterioration. Repeated themes I have already shared with you. EDIC will be trying to test the ability to identify pulmonary contusion, hemothorax, pneumothorax. Again, the differential diagnosis, the ultrasound finding, what will the management, the ICD management, all these things would be asked. In this exam also, they have asked about pneumothorax, ICD, and the management. Whether you want to go with the chest tube, whether you should be waiting for some time for intubation, and how we are going to manage the ICD. So key message, not all hypoxia after trauma is pneumonia. Now hot domain 5, acute abdomen with shock and AKI. This is something again and again getting repeated. And the CBS, they would be sharing with you abdominal CT scan. They would be putting one clinical case scenario on AKI plus distension plus pain. Again, elderly with abdominal catastrophe. And EDIC will be trying to expect ischemic bowel, perforation, intra-abdominal hypertension, and your skill should be recognizing the surgical emergency. Now, previously you were dealing with the medical emergency, GBS with acute respiratory depression. Here, they expect you are thorough with the surgical emergency as well, and avoid diagnostic paralysis. And they would be really impressed if you can utter this word: patient needs urgent surgical review or exploration, not more imaging. Now, ECG based clinical diagnosis, as Dr. Jitendra has already told, multiple questions were asked about this ECG based problem, like hypothermia ECG, Holter strip post syncope, seizure plus ECG, something or other. So you need to have a question bank on the ECG where all the combinations of ECG with clinical vignette, all the types, all the patterns, all the trends that would be within that question bank, and you would be repeating it, revising it well. Now, key ECG concept tested: Osborne or J waves, malignant arrhythmias, electrolyte domain changes. And nowadays, again, just like the X-ray or the CT scan, ECG interpretation is linked to the physiology and management, not only the rhythm naming. Now, they are not expecting that you should be only answering Osborne J wave, Brugada syndrome. No, rather they would be expecting how we are going to manage. What is the pathophysiology of this type of waveform? Something like that. Okay. Last, I would be saying advanced hemodynamic monitoring or interpretation. Yes, examiner focuses on CBP, prominent A wave, obstructive shock physiology, some or other the IABP waveform, and some or other the different CRRT, the tracing also. So these are some of the questions that have come up in the recent last 2 or 3 exams. Numbers are useless unless you understand the waveform. Coagulopathy and ROTEM. Yes, this is also in the last 2 to 3 exams. They are frequently asking the ROTEM and the coagulopathy questions. They expect that you should be differentiating factor deficiency from the fibrinogen deficiency, and again from the hyperfibrinolysis. And their target is blood product therapy, not blind FFP, blind platelet, or blind packed cell volume. So the idea is move from FFP per all to the goal directed hemostasis. Ventilator waveform pathology, we all know this is again a hot domain. Autopy, patient ventilator asynchrony, flow starvation, double triggering. So the EDIC examiner, they expect that you should be very thorough with the waveform abnormality. And again, it's not the abnormality, also how you are going to propose specific ventilator adjustment. So the key trapping here, naming the problem without fixing the setting. That means you are only trying to say the problem, but they expect you should be the problem solver. Troubles not to be escalated, rather trouble should be solved. Acid-base electrolyte-driven emergency, we all know these are the frequently asked question, and the examiner expect that you are integrating the interpretation in a proper sequence, the cause, the consequence, and how you are going to correction. So they would be like making one story, not separate questions. Now the last slide before I will be hand over to my the invited faculty. EDIC to CBS success formula again would be pattern recognition, prioritize like the best versus the correct, and issue appropriate next step, and avoid over investigation. That means you should not be only telling about the test, rather the minimum test and maximum impact. And the last bottom line, think like an intensivist, not an examining. That also they expect. And one line take home message, EDIC 2 rewards judgment, prioritization, and ICU thinking, not only rote knowledge.
Good evening, everyone. I am Fadil Ibrahim. Thank you, Dr. Tabas. Thank you, Dr. Sananta Jitendra, for this. I will speak quickly for mock evaluation insights and how to maximize your marks with the structure. We will take in 7 tips. Tip number 1, just reading strategy. Optimize your 5 minutes vignette review. You will give, the examiner will give you some minutes to read the vignette and to write down your critical information. Very important, use only half to 2/3 of your time. Try to minimize the time, ensuring you haven't missed important details while writing. This is very important because you will take time with the examiner in the oral examination and to have time to organize. But you have to first organize your thoughts, use final moments to structure your approach before the oral discussion begins. This is a time management strategy that ensures you enter the discussion with a clear, organized mental framework rather than rushing through your reading. This is very important. Time management. This is step number 1. This is a case scenario that brain abscess with space occupying lesions. This is very quickly. The clinical scenario starts with a patient with low GCS CT revealed a lesion with high pressure edema and the air with necrosis. What is the critical safety point? They asked you, the examiner will ask you how you will diagnose the infection. The most important thing is to avoid lumbar puncture due to raised intracranial pressure, and you should be aware about the signs of high intracranial pressure in CT. Also, give you a golden rule. The organism name. The examiner will give you the organism name like Micrococcus luteus. This is a very distractor or the distractor principle of management, but the management stays the same regardless the name of the organism. The structured approach, you will start by ABCDE, diagnosis for CT and MRI, followed by a biopsy or aspiration, treatment, empirical antibiotic like vancomycin, ceftriaxone, meropenem, metronidazole, adjunctive like seizure prophylaxis as needed. Tip number 2, precise the name and the site of injury of the medical device. This is very important. If they will give you a CT like this, you should always name the object, the site. Don't say central line or central venous line. Specify whether it is right or left, whether it is a dialysis line or a CVC. Include the laterality. Say left intracerebral hemorrhage or left intracerebral or intercostal tube rather than just saying intercostal tubal chest drain. Why this matters? Precise terminology demonstrates attention to detail and the clinical accuracy, and this is very important for the examiner. This is one of the example of the computer-based scenario. 78 years old male, known to be hypertensive, presented with acute left-sided weakness and decreased level of consciousness. This is the CT brain showed. What is the side involved? You should say on the right side, you should say intracerebral side, and you should say the left ventricle. And he will ask you, what is your target blood pressure control in this case? So if it came in the vignette, like the long vignette, and he is asking you, if you are saying that less than 40, our target is blood pressure is less than 140 millimeter mercury, he will ask you, what is your evidence? This is a very important question. So you should be aware about the evidence from the major trial supporting the intensive blood pressure lowering in acute intracerebral hemorrhage, like the INTERACT trials from 1 to 4 and the ATTACH trial in 2016. So always remember when he will ask you what is your evidence. So tip number 1 is to time management of the vignette. Tip number 2 is to say the laterality and the size and the exact site of the pathology and the device. Tip number 3, understanding the pulmonary artery cluster. You know that since 2005, they stopped, or the pulmonary artery cluster using was becoming decreasing in all over the ICU, all over the world after the Beckman trial in 2005. But after the COVID era, I think pulmonary artery cluster is coming back, especially in cardiogenic patients. So you should be aware about the pulmonary artery cluster. You should know the common errors in the cardiac output measurement. This is very important. For example, you should know where the ideally place of the pulmonary artery cluster, and you should know where it's the exact site of pulmonary artery cluster insertion on the X-ray. This is also what does the red curve represent, and give example for this hemodynamic assessment tool. This is the red curve represent the high cardiac output monitoring in pulmonary artery cluster or thermodilution. This is very important. The catheter tip should be within 2 centimeters of the hilum and should know start to be aware about the pulmonary artery cluster, because nowadays you will start reuse again. Tip number 4, the patient safety is a paramount. Remember, the examiner is testing your patient safety. Every answer should demonstrate that you will not harm the patient. This is 2 examples, the left side CT chest and the right side CT chest. What the left side is demonstrating, you can illustrate. This is a left basal lung bully. The other one is a right tension pneumothorax. It will give you in a vignette or a scenario that the patient have a low blood pressure and desaturation. Actually, they will give you the CT, but one lung will be tension pneumothorax and the other lung will have bully. He will ask you what you will do. Please be careful. Don't say I will put intercostal tube in the left basal bully or in the bully, because it will create a very harm to the patient and bronchopleural fissura. You should be very away and very specifically for the patient safety. This is very important. The examiner is testing your patient safety and how you will deal with him without causing harm. Tip number 5, connect multiple images to form a complete clinical picture. This is one example for 2 images. The examiner will give you in the clinical based scenario in the CT or the imaging, he will give you 2 pictures. You should illustrate the 2 pictures and connect them. When given 2 pictures, interpret each clearly to link them together to demonstrate integrated clinical thinking and find the final diagnosis. The first image, this one, is the right intracerebral frontal and parietal hemorrhage due to rupture mycotic aneurysm. Why I said mycotic aneurysm? Because the second image is showing a genuine lesion suggesting infective endocarditis. Linked together, this patient likely has infective endocarditis complicated by a rupture mycotic aneurysm causing intracerebral hemorrhage. Don't miss this step. This is very important. You should illustrate the 2 picture or any picture that the examiner will give you. Tip number 6, use always the clinical context as your guide. For this CT, they will give you this CT. What is your diagnosis? If you are given a scenario such as a CT of a male patient after transesophageal echo who now has a chest pain, use the hint from the anticipated what you might see. In this case, think of esophageal rupture. If you don't know, but you should know, you should be aware about the CT and different scenarios. From this CT, from the scenario, he gave you that this patient have a male patient after TE have chest pain. Most probably this is esophageal rupture and this is air pockets. This is a rare but serious complication of TE. Recognizing the link between the procedure and the complication will help you to interpret the image correctly and give a complete answer. Tip number 7, this is very important to all to know. This is the station and this is the final. All inshallah will get passed by the EDIC part 2. You will have 2 stations. EDIC part 2 structure are 2 separate components. Clinical case simulation. 3 station must pass at least 2 out of the 3 stations. Clinical basic science or computer-based science, 3 station, also you must pass at least 2 out of 3, like this. It is important you need to pass both components independently, CCS and CBS, to be considered successfully in EDIC Part 2. Failing one compartment means failing the entire Part 2, even if you pass the other. Thank you.
Hello everyone, hello, I am Dr. Abdel Karim Al-Manawi. I am working in Saudi Arabia, and thank you for having me today. And I'm excited to join the EDIC exam again after this lectures. So I hope for all attendees to be successful, inshallah, and learn from this topics, inshallah. Mission not impossible, just avoid common mistakes. It is okay to make mistakes. Mistakes are our teachers. They help us to learn, but don't ever make the same mistakes twice unless it pays. Our Prophet Muhammad said, لا يلدغ المؤمن من جحر واحد مرتين. A believer is not stung from the same hole twice. And I love this book title, Mistakes That Made Me a Millionaire, how to transform these mistakes to steps for extraordinary success. So I hope to all will be a millionaire after this lecture. A smart doctor not fail due to the defect or gap in their medical knowledge, but due to failure of avoid the common mistakes, and often it is a strategy gap. The common mistakes during preparation, especially in CBS or in general, study alone without any help from others. Study hard and read text only. Sure, you need to study, but in smart way. Not practicing the exam style, as our faculty said, you need to know what is the exam style and try to practice. No expert courses after studying to approach your information. A random approach, no clear sources or resources, no plan for difficult and unfamiliar question and cases. So to avoid these mistakes, first start study in a group discussion exposed weak point faster, then study smart, not hard, focus on pattern, framework, and exam logic. Practice daily, not occasionally. Use expert courses to shorten your learning curve, like this course, 36 TRICS course, and the mock exam. It can help you during for exam and prepare for and guide you for the exam. Build structured thinking. Build system for your information. Choose your resources early and stick to them. Prepare plan for difficult and unfamiliar question and how you will react, how you will reason, and try to be or stay safe and hit the answer quickly. Examiner always waiting you to answer in structured way, despite if you didn't reach the specific diagnosis or management. Here, there is some mistakes before the 24 hours of the exam. It is simple, but I think it's with big effect, like poor internet setup, like relying on single internet sources with no backup. So you need to use at least 2 internet sources, prefer wired internet instead of Wi-Fi when possible. Keep a phone hotspot ready, test speed stability, and remember exam organizer usually schedule equipment check at least twice to treat like this problem. Also the other common problem, poor lighting and room setup, like dark room, noise, interruptions. So you need to use good light sources, quiet private room, close the door, clean desk, open, clean desk, and you can use only some pens and paper of notes. No equipment check like laptop issues, mic, camera problems, low battery, sleep mode. So you need to fix all of this. Also, wrong mental state like anxiety, overthinking, depression. So you need to be relaxed, breathe, and remind yourself you are prepared, you are ready, and try be confident and be in faith with God. Dressing professionally, it changes your posture, your attitude, your voice, and your confidence. Poor screen setup like messy screen, notifications, distraction. So you need to close all apps, silence the device, and how to minimize or maximize, sorry, how to maximize the exam screen. And this is mistakes during CBS, most common mistakes, and no practicing, poor screen as discussed before. If the examiner window distract you, try to minimize it to the corner or move it if allowed. Keep the laptop plugged in. Overthinking and over talking. Poor time management. I think this is the commonest mistake. Need to address it and practice on it. Answering the question you wish they asked, not the question on screen. You must read question carefully and answer this question, not the question in your mind. Hesitation, doubt, giving too many answers, missing clues, red flags, and keywords. To solve this problem, you need to follow my 6S approach. When question hit you hard, stop for a few seconds. Don't panic. Be slow, simple, structured, safe approach. You will solve this easily, inshallah. Sometimes in CBS, you can't answer this question, so you can skip it. Later, when you have time and mind be clear, you may return and solve it easily. This is example for CBS. Sometimes the ECG or imaging is not the trap. The trap is missing the clue. This example of ECG for massive pericardial effusion or tamponade. Read the question carefully. It guides you for the answer. Here, this is the ECG. The question is interpret the ECG. Don't go with complete analysis. You can say low QRS voltage, sinus tachycardia, electrical alternance. So this is with the massive pericardial effusion or tamponade. So patient here is hypotensive. So the question, the best management here is the clinical and clinical assessment and echo assessment for tamponade, and we'll go for pericardiocentesis. If you don't pick the clue or key the word, you can think loud. As I said, in simple, structured, safe way, you will reach the diagnosis, or at least make the examiner see how you thinking and reach to the diagnosis and manage safely the patient. But here must be simple, concise, targeted answers. Also, this question may make your mind is blocked. Don't panic if you are not familiar with DCT and the history make you confused. So again, you can skip this question. And at the end, if you have time, you can return to it and solve it by simple, safe approach. This is the female with advanced ovarian cancer, bedridden, complain from right lower limb pain. So the CT here is there is no lung, no pulmonary angio, only abdomen or pelvis CT, coronal section, the body with some air, foci under the skin. So this is not BE, it is necrotizing fasciitis. And the best management is urgent surgical debridement and consultation for surgical team and first hour sepsis bundle, like as Dr. Tabas said, culture and B also systematic culture antibiotic, and discuss, and the important thing is discuss with the surgical team for debridement. Be simple, structured, use safe approach. So also this case, you need to scan quickly. You have at least I think 30 to 40 seconds to scan all this slide, pick up the clues in the case scenario and labs, connect all to make the diagnosis and differential diagnosis. Be also short, simple, targeted diagnosis and differential diagnosis. And also here for best investigation, you need also targeted investigation and also for management. Here, this patient have TTP, thrombocytopenia, and differential diagnosis is TTP, ITP, hemolytic uremic syndrome, DIC, other causes of thrombocytopenia. But here, this is go with TTP because patient have fever, anemia, thrombocytopenia, renal involvement, and neurological complication. So the best investigation, you need to diagnose. So you need to be spot histiocyte, anemia, ADAMT S13 level, and best management ICU admissions, plasma exchange, and no platelet transfusion. And try to make during a study like this question, use some mnemonics and some structured way to thinking to be easy and to pick up during the exam quickly. In second day in CS station, here the structured thinking and approach appear. The common mistake here is no practice, no structure. Both are the main mistakes. Not taking notes within the allowed time, jumping immediately to the diagnosis, not handling deterioration well, too complex answer, and forget teamwork like multidisciplinary meeting, call help from seniors and consultant, and also involve family for decision making. In this question, when you receive the vignette, there is a few minutes to think. As Dr. Fadl said, I think it is 5 minutes. So you need to prepare yourself quickly and put notes in trained notes format. Put your primary diagnosis, then plus 1, 2, 3 differential diagnosis. What is your management approach? What is the expected complication? And what will you do if patient deteriorate? Like examination of the patient, investigation, call for help, discuss with the multidisciplinary meeting, family engagement, and sometimes discuss goal of care and discuss organ donation here, like cause VCS is 5, and maybe a patient have his potential for organ donation. So all these need to discuss and remember and be trained to remember this plan if patient deteriorate or patient have some complication. Also, there's some debate question like early versus tracheostomy. Patient have thrombocytopenia and patient have thrombosis. So you need to train yourself on some debate question and how can take decision in a safe way. Brain death assessment and management also need to train yourself in these questions, and also about the withdrawal of treatment and goal of care and the family meeting and call seniors and involve, as I said, other teams. Escalation and escalation of treatment. Here, like this patient maybe need craniotomy, or you need to don't go direct for craniotomy. You need to have approach or evidence in your decision about craniotomy. If you don't have this clues or don't have this evidence, don't go direct for craniotomy. But you have ask other teams about their plan and what is the plan from this point for craniotomy or no. Also, in some cases like ERDS, don't rush on ECMO. You must go step by step till reach the criteria or the clues make you your decision of ECMO is best choice and safe choice for the patient. Manage as you are in your ICU, but at least 3 or 4 differential diagnoses. First one is the possible diagnosis or correct diagnosis. Think as you are consultant. Involve seniors, call for help, ask MDM, family meeting, especially in decision making. Use targeted answer with rationale, involve only when indicated. Invasive only when indicated. Be simple, safe, structured, self-confident, and be smart. At the end, the common mistakes after the exam: not reviewing mistakes, emotional exhaustion and panic, not modifying strategy after failure, stopping practice completely. So you need to rest, then return to practice, review what went wrong, adjust and modify your strategy, write the recalls for helping you and for next people or next exam attendees of the exam. Learn from your mistake and enjoy the race. Mistakes are proof you are trying, but correcting mistakes is proof you are growing. Thank you.
Thank you very much, Dr. Abdel, and it was really very impressive, and definitely the messages, the quotes that you have used is motivating for all the attendees to prepare confidently in their upcoming exam preparation. So with this, we come to almost end, but before ending our today's webinar, this is the course that we are coming up, and the agenda I am shared with all of you, and the course starts on 17th January 2026 and it will end just before your exam, which is scheduled on May 2026, and everything would be covered in this upcoming TRICS 2. Like enrollees will gain exclusive access to the TRICS 2 cloud, where we will be depositing all the resources for the EDIC2 preparation. Again, 11 modules, each with a section wise mock test, just like the real exam, and again 2 full syllabus mock test at the end, which would be 1-to-1 live, and you will be getting the real exam feeling. And each weekend there would be a live debrief for 11 weeks in one go, so that you will be getting again and again the practice and the exam style preparation all through like the Zoom. And this is the agenda that we have created, very scientifically tried and tested for last the exams. And you can see it starts from 17th January and it ends on 26th May, and you can go through all the domains of the critical care. And this time we are coming up with exclusive small videos, small bites on the specific CBS, because this is something which we got in our feedback from our candidates, that CBS maybe we need to prepare in a better way, confident way, and that's the reason why we would be creating all the CBS probable questions in small videos, small bites, and that process has already started, and definitely it would be helping the upcoming trainees or the examiners. And please contact the team for the details, the upcoming the courses details, and also there are certain early bird offers also. If you are joining in a group, definitely there would be very impressive discounts for all of you. Thank you very much, all the faculties, Dr. Sananta, Dr. Jitendra, Dr. Fadel, Dr. Abdel Karim, and our technical team, the Bhagyasri and Navneet, for helping to conduct this webinar flawless, seamless, and hopefully we would be serving the purpose with which we have taken the mission as 360 Critical Care. Thank you very much. Merry Christmas in advance and Happy New Year to all of you in advance. Hope your dreams will come true in the 2026. Thank you very much.